and decided that I would use that as kind of an organizing principle. And first of all, let me thank you for the chance to be here and to speak to you all on what is obviously a hugely important topic for everybody here in the Commonwealth, which is healthcare costs. In Massachusetts, anyway, I think you can all agree that healthcare costs and sort of everything about healthcare is kind of a conundrum. We certainly have what most people would call a world-class system, and folks come from all over the world to access our service delivery system here. It's also hugely expensive, but it's hugely expensive on an absolute basis. If you look at the cost of healthcare in Massachusetts as a percent of personal income, we're pretty much right in the middle of where the rest of the country is, which is one of those things that often gets lost in the conversation. It's a major employer at the same time that it's a major cost center. But if you were to ask me what I hear about from employers, and I'd be curious to hear what Rick Lord would say about this, most employers talk more to me about energy costs than they talk about healthcare costs. They talk about housing costs more than they talk about healthcare costs. They talk about regulatory policy and how long it takes to get something done more than they talk about healthcare costs. Now, that could be because of the percent of personal income calculation, which means they just view it as part of the larger issue around total compensation that exists here in the Commonwealth. But it's definitely one of those things where, while it certainly is expensive on an absolute basis, if you look at it in terms of the cost of everything in Massachusetts, it's on the list, but it's definitely not at the top. It's also a huge global cluster for the Commonwealth, and it's one of the things that is part of the Massachusetts and the Boston brand, and one of the most important elements of sort of our position in the global economy, especially when you think about biotech and health IT and big data and a whole series of other initiatives and issues that represent ways in which the healthcare community contributes in a big way to the economic vitality of the region overall. Now, with respect to what to do about that, which is really what you'll all be talking about over the course of the next few days, first panel's on the benchmark, and that one I find kind of interesting for a bunch of reasons, the biggest of which is the number of variables that you have to factor into calculating the benchmark to come up with some way of feeling that your calculation represents something that's not being driven by forces that are beyond everybody's control. And what I mean by that is, let's take addiction, for example. Addiction is a big issue, especially opioid addiction here in the Commonwealth, and you can't put more than 20 people in a room without running into somebody who's been directly affected by it. And I would argue that one in particular, the healthcare world's had a lot to do with, since 80% of the people who end up addicted to heroin started on prescription pain meds, and the number of prescriptions that have been written for opioids has gone up fivefold over the course of the past 15 years. Now we can debate why that's the case. My own view is my colleagues in the healthcare world have not been as aggressive about understanding the downsides associated with many of these medications as they've been about understanding and appreciating the upside. And that was one of the reasons why we asked the folks at the 4 major medical schools to come in and spend some time with us. And while there's certainly curricula that's been developed for medical school students around pain management and addiction, it's not a core requirement for graduation. And it's pretty clear that a lot of people get through medical school without really ever spending any time at all on pain management or addiction generally. You have to deal with all the issues associated with changes in Medicaid. The biggest one, of course, showed up in your report last year, which was the rolling of somewhere between 350 and 400,000 people into the Mass Health program to deal with the crack up at the connector and the 19% increase in Mass Health spending that came with that. We've been aggressively pursuing a redetermination strategy for all of the folks associated with that process, which I'm sure the Secretary can speak to in more detail than me, both secretaries. But the bottom line is we're pretty much all the way through that. But along the way, that created all kinds of sort of one-time issues associated with your process that created variability that wouldn't have been there otherwise. I also think that, I don't know how you factor demographic information into this. I mean, I'm 58. I'm right in the middle of the baby boom population. The baby boomers are basically 68 to 48. Their role in the healthcare world is going to get increasingly complicated over the course of the next 20 or 30 years. Their parents are, generally speaking, well, somebody said to me the other day that, 60 is the new 50, 70 is the new 60, 80 is the new 70, but 90 is 90, which I thought was an interesting way of thinking about what you all are working through and trying to deal with respect to demographic trends. And then, of course, there are all the issues associated with technology. One of the things that has always been complicated about healthcare is the system's ability to do more things comes with in many cases, a societal benefit that's uncalculable. You can certainly calculate the price associated with the fact the system can do more things, but the ability to calculate what the benefit to society overall associated with that is very hard to do. So I do not envy you with respect to trying to figure out how to create a benchmark over time that can adjust for and control for many of the factors that need to be incorporated into how you make decisions about deciding whether the benchmark well, there's a hard calculation around whether the benchmark's been hit or not, but then there's a second level calculation around what the elements associated with getting there are, and then what could be done about it, or what might be done about it going forward. With respect to primary care access generally and the overuse of acute care services and institutions, this is an interesting question to me, and I say this as somebody who is a big believer in primary care access and would like to see more of it. I actually think all of the cognitive stuff, primary health care, pediatric services, behavioral health, and mental health, those are all sort of categories and care delivery, components of the care delivery system that tend to get treated differentially, I guess is the way I would put it, by the Medicare program, which for all intents and purposes is the big dog in the system on a payment basis and the one that pretty much determines how everybody else pays for everything. And if Medicare pays a lot less for mental health, behavioral health, and primary care and pediatrics, then it pays for dermatology or radiology or pathology or a whole bunch of other things. Everybody else will too. And that's pretty much been the way the systems work, because everybody calculates everything into a Medicare fee-for-service equivalent, and that's the way people keep score. The problem that creates when you're trying to develop program models that make primary care a bigger piece of the drill and acute care and hospital-based stuff a less significant piece of the drill is you're always playing from behind if the Medicare program just continues to do what it does in terms of how it values what it thinks is important and what it's willing to pay for. And I say that as somebody who, generally speaking, would like to see us do more with the cognitive stuff. But I start from the proposition that it's harder to do that than it should be, because Medicare is just going to keep cranking its own crank on what it thinks the most important components and elements of the healthcare system are. And the place that really affects all of us is in trying to determine within that framework a system that tends to be more heavily weighted toward academic medical centers here than you'd see in other parts of the country anyway, And academic medical centers, for all kinds of reasons, tend to be more heavily weighted towards specialty services to begin with than they are toward primary and cognitive services. And that's a function, again, of not just Medicare, but also federal policy with respect to the way the NIH works, and where research money comes from, and what the feds value. So my point there is that flipping the paradigm or changing the equation with respect to primary care and everything else requires the Commonwealth to somehow climb over or work against trends that are coming from the federal level that have a much bigger influence on anything we can do here in Massachusetts. Now, with respect to payment reform, I mean, it's very clear from reading all the documentation that was put together for this meeting that almost everybody on the payer side believes that there's somewhere between 60 and 80% involved in alternative payment methodologies of one sort or another, and the typical number of their percent of their members that are represented by that is somewhere in the 50 to 70% range, and the provider community, for the most part, had similar kinds of numbers in a lot of their presentations. That's a big piece of the puzzle there. If folks really believe that they're already, for the most part, either serving on the provider side, more than 50% of the folks in some sort of alternative payment methodology, or folks on the plan and the payer side think they're already engaged in arrangements where 50 to 70% of the patients, or 60 to 80% of the members, or 50 to 70% of the providers they do business with are on alternative payment methodologies, then it's already more than half the traffic and the activity that's involved in there. Now, I don't know how people are calculating the denominator and the numerator on that, but it's pretty clear that a lot of the traffic that's currently taking place in healthcare in Massachusetts is under some form of APM. So what does that tell you? It tells you that while it may be directionally correct, it may or may not be having the kind of influence people would like to have with respect to what actually happens every day on the ground in terms of healthcare delivery, because you still have some of the same issues with respect to primary care and specialty care. You still have some of the same issues with respect to academic medical centers versus community hospitals. You still have a lot of the same issues that people felt moving to APMs might have an impact on. Now, it could be that it's early and that over time the APMs will start to have a more significant impact on some of those issues than they've had so far. But this is clearly, Stewart had a great line one time at a conference I was at where he said, if you're talking about gradualism, where you start to land the plane that's going to land in Boston by starting to lower the altitude in France.
You remember?
I do. It's the greatest line about the gradual approach we take to a lot of things in healthcare. And I wonder sometimes about whether that's part of what's going on with the APM stuff, which is it's important and it's directionally correct, but it's very incremental with respect to its ability to truly change some of the things people care about with respect to the way the system works, because you have other forces that are at work that are pushing the thing in a completely different direction than that. The other thing I would say is that the dual eligible program experiments that are going on, which are in fact not just alternative payment methodologies, but full-blown bundled payments, and not bundled payments in terms of the way Medicare thinks about them, but bundled in terms of putting Medicaid and Medicare together into a single payment for services, and then having people try and treat folks that way. The jury's still out on whether or not that over time, whether that has worked in the short term and whether over time it can work in the long term. And that one, to me anyway, is probably as good an opportunity as any we're going to have to think differently about payment and service delivery with a population that, in my view, if we got this one right, you could have a real win-win where people will get a much better and more proactive approach to care delivery, and at the same time not have the kind of fragmented approach to services that has historically befuddled and bedeviled a lot of people who fell into that category. Now, with respect to network construction and the impact of network construction on healthcare costs overall, I have a fairly simple view on this. And I'm actually glad that Norm is sitting right behind me here. Lowell General Hospital has been a low-cost, high-quality provider since I was Undersecretary of Health and Human Services in 1991. Okay? That was 25 years ago. So for 25 years, we've had at least one provider organization that's been a pretty good example of how you can do a terrific job of serving the folks in your community and doing it at a price point that everybody would agree is significantly below the statewide mean. Okay? You owe me $20. Lowell General is not the only care provider in Massachusetts that falls into that category. There's a bunch of others. My point here is whether they were getting paid on a fee-for-service basis or on an APM or under a global cap, that wasn't what made them a low-cost, high-quality player. What made them a low-cost, high-quality player, in my view, was the culture and the approach that they took to what it was they were doing and how they delivered care day after day after day, month after month, year after year after year. And I think sometimes at a high level we think if we could just tweak this or tweak that, somehow we could move the system. When I look at the data historically, and I think some of the AG's reports on this would bear me out on this, the way people got paid had less to do with whether or not they were a low-cost, high-quality player or a high-cost, high-quality player than just the attitude and the approach they took to what it was they were doing every single day. And there's certainly something to be said for the notion that in some cases payer mix has some impact on that, but Lowell General's payer mix has always been, I think, against the statewide mean, probably. You do at least as much public stuff as, yeah, you're a dish. So I don't think of it, I mean, it's clear to me that it's not the way, it's not who pays them or how much they get paid. It's just the way they go about doing what they do. And I don't think we've ever done as good a job as a Commonwealth as we could do in really understanding why some folks just seem to be better at being low-cost, high-value players than others. Which brings me to the transparency question, which is, I would really like to see us, and I apologize, I've been governor for 9 months, but I've been a little distracted by a whole bunch of other things that have come up along the way. Winter's right around the corner. But I think you can expect to see us get a lot more aggressive about the transparency stuff in 2016. It's always troubled me that if you are a low-cost, high-value, high-quality player in healthcare, there's really no way for anybody to figure that out about you. And we've got to do, in my view, a much better job of really leaning hard into the whole transparency piece if we ultimately want to be successful. And the other thing I would say about that is it's not just about there's a whole bunch of different ways I think the transparency piece would matter a lot. I think it would change the dialogue around the acute service piece versus the primary care piece too, if we did a better job with transparency. Because some of the differentials there are staggering, and most people would never believe them until they actually saw them. But since most of the people who know about them tend to be people who spend a lot of time swimming around in healthcare data and not really much of anybody else, I think that's a problem that we have got, and I'll take some of the hit for that. We've got to do a better job of making that available to people. And the final panel you folks have put together is the one that sort of talks about what next, and that in some ways may be the most important one of all. But I'll give you my 2 cents on this. And the way I thought about this was a little different maybe than the way you thought about it, which is I said, with respect to patients, what do I think our great challenge is? And I think our great challenge with patients is we have a system that's built for the 95% of the population that gets sick once in a while, but for the most part is reasonably healthy. It's not built for the 5% that's very sick and very complicated. And you can call it an 80-20 game or a 95-5 game. I don't much care. The numbers sort of work for either population breakdown. But the bottom line is the system's organized still now, today, for the most part, as a transactional system that's designed to serve the folks who are relatively healthy and have an occasional interaction with it. It's not designed to serve the people who are managing 2, 3, 4, 5 comorbidities, who are very sick and dealing with all kinds of, who are ambulatory for the most part and dealing with all kinds of significant circumstances and complications. And the fact that we haven't really figured out what a strategy is to support caregivers, and I mean when I say caregivers here, I mean both the professional caregivers, but also the non-professional voluntary caregivers, family members, neighbors, brothers and sisters, moms and dads, sons and daughters. The fact that we really haven't figured out how to incorporate them into the way we think about care delivery generally for the 20% that's really sick and needs a different kind of way of thinking about this is kind of indicative to me that we have a long way to go there. And on the patient stuff, I can tell you that one of the things I'm going to want us focusing on is how do we do a better job for the 20%, the 5% that really do represent the folks who are truly managing every day complexities in their own physical and mental health, and stop and not think the whole thing needs to be designed around the folks who are relatively healthy and have an occasional opportunity to engage with the healthcare system. On the clinician side, this is a problem that I don't have a solution for yet, but I've been thinking about it a lot, which is probably troubling, because if I've been thinking about it a lot, I should have come up with an answer. But at exactly the time when I think we would benefit from being a little more general in our knowledge and understanding and a little more team-based in the way we went about care delivery, we seem to be getting more and more specialized and more isolated in terms of how we think about healthcare on the clinician side. And if you were to say to me, in addition to the fact that I don't think anybody should be able to graduate from medical school without taking at least one course that creates a core competency in pain management addiction, the other thing would be in team-based approaches to care delivery and a recognition and understanding that for the 20%, the 5% that are really sick, the only game that's going to work for those people is going to be a team-based approach to care delivery on the clinician side. The system isn't organized really to do that. It's not financed to do that. And we have a long way. And this is one where I do believe, if we are directionally heading in the right direction for this, I think we're probably a little bit past France, but we have a hell of a long way to go to get to Massachusetts. But this is one where if we really want to do something for patients, especially those who are dealing with multiple conditions and circumstances, we've got to figure out a way to educate clinicians and support clinicians around team-based approaches to care delivery at a point in time when I feel like we're heading in the opposite direction and just getting more and more specialized in the way we think about care delivery and medical education and everything else. I get the fact the system's more complicated. It's more technically sophisticated than it used to be, but there has to be a recognition and understanding that team-based approaches, especially to complex patients, is really a much more effective way to serve and take care of them. On the hospital side, there's going to be an ongoing struggle around inpatient and outpatient services and care delivery that's going to be driven by a lot of things. It's going to be driven by technology. It's going to be driven by patient choice. It's going to be driven by payment systems. It's going to be driven by a bunch of different things. And for a place like Massachusetts, which has such a big installed base on the inpatient side, I'm not exactly sure what that means. But it could be extremely disruptive and not necessarily a bad thing. On the other piece about this is most of our ambulatory care providers, whether you're talking about urgent care providers, emergency service providers, primary care providers, mental health providers, even community health centers, in Massachusetts, they're almost all hospital connected or hospital driven. In most other parts of the country, they're not. They're typically freestanding. And if you look at the Mayo Clinic, for example, the Mayo Clinic is basically a big physician, multi-specialty group practice. And unless you're really deep into healthcare, you don't even know the name of the hospital that they work with. St. Mary's. Okay? Now, the reason people don't know that is because the system is organized around the group practices and around the ambulatory system. It's not organized around the inpatient hospital facility system. In Massachusetts, the system is much more organized around the hospital piece, not so much around the ambulatory piece. And I don't know how to change that. I'm not sure we should change it, but I'm telling you that as some of these other issues play out over time, it's going to create a very significant issue for everybody who's part of the care delivery side of the equation. On the two other things I just want to mention quickly, one is pharmaceuticals and the other is technology. On the pharmaceutical piece, I guess what I would say is that I think I have a hard time seeing past the opioid piece these days because it's been such a big part of our focus. But with respect to that one, I do believe we, as a Commonwealth, and probably as a country, have not been as judicious in the way we've gone about prescribing those medications as perhaps we should be. And it makes me wonder how we've been with respect to lots of other medications as well. I get the fact that the debate most of the time is about the price point of drugs, but the other piece that's, in my view, equally important when it comes to drugs is the prescribing of drugs and how we choose to use them. And on that one, while I certainly think there's a debate to be had and should be had around the price point, especially with regard to certain medications that seem to magically change their price point, I think there's another question associated with sort of the way we as a community prescribe and access them. And on the technology piece, I think that there's really good news in the technology space. I mean, I'm a big believer in automated medical records and clinical practice supports and all the rest. And that train seems to have left the station and is moving at a pretty high rate of speed. And I think has the potential to significantly enhance and improve the quality of healthcare and help us come up with smarter and better ways to do team-based approaches to complex populations, as long as some of the process barriers can get broken down, and to bring a very different and more substantial approach to supporting clinicians and, frankly, patients over time with respect to the way they perform. But the flip side of that one is we are going to have a lot more information that's digitally available, which I'm sure is going to create some concerns for many people around some of the HIPAA issues associated with privacy. And I do think this is something I would like you guys to think about, which is how can we make sure we get the most mileage out of big data and out of all the information that used to be in paper records that's now going to be digitized and organized in a way where on a de-identified basis it could provide a lot of guidance and a lot of support to people both on the practice side but also on the patient side with respect to what the best way to deal with certain kinds of illnesses and conditions would be. I mean, I think it has tremendous potential to be a big positive, but if we don't deal with some of the rules around process and access and all the rest, it may not ever amount to what it probably should be. And then the final thing I'll say, and then I'll be happy to take questions if you have time. The demographic trend combined with the technology trend is not something that can be ignored. We are getting older as a society, and Massachusetts in particular is getting older. And with that will come all kinds of interesting challenges on the healthcare front that are just sort of driven by that and undeniable. Combine that with the technology and the ability of the system to do more and more things for people, and it will create some real challenges with respect to our ability to hit the benchmarks. And the final thing I'll say is that I would really like to know and understand more about why the Lowell Generals of the world have continued year after year after year to be very strong players on the quality side of things, and really strong players on the cost side, but haven't become kind of the center of the way we think about healthcare and talk about it. I mean, almost all of the strong players in that space don't really get a heck of a lot of time or attention, and I absolutely believe there's something to be learned from what it is they've been doing. And again, I appreciate the chance to speak before you and look forward to working with you going forward. Thank you.
Would any of the commissioners like to? Yes, Dr. Hattis.
Governor, thank you for your comments. You've talked about a lot of different areas, but let me focus my question on the issue related to Lowell General, because it's sort of an issue that I feel like I've been a broken record about since I became a commissioner, which is both about the culture, but in a metric sense, we don't know very much about, for our providers, especially our hospital providers, what it costs them to deliver a service, a gallbladder surgery, an outpatient endoscopy, whatever. So my hope is, especially with you and the administration's interest in transparency in 2016, that some of the energy can go into focusing on us understanding that better. I mean, I know there's some research going on at the University of Utah to try to, get at issues like this, but I think unless we could get that kind of information and compare, we're sort of always left wondering that if when providers want more on the revenue side, whether or not it's happening because they really have the need or it's an efficiency issue. So,
yeah, I agree with that. I think one of the amount of work that's been done in what might be called activity-based costing in healthcare is pretty minimal compared to what you see in a lot of other spaces. Most of our cost work has been done around revenue-based costing, which is a slightly different model for all the reasons you expect.
One quick comment, though. You did say at the beginning how you talk to employers and they don't tend to bring up healthcare issues. The thing I want to say is, when I talk to my GBIO colleagues, who are often the employees, when they see their deductibles going from $500 to $1,000 to $2,000, or their kid who needs outpatient mental health and the provider doesn't take any insurance and they're all paying out of pocket, they talk to me a lot about the burden of healthcare costs.
Absolutely right. Yep, absolutely right.
We'll take one more question. Yes.
And Governor, you asked me what we're hearing from our members as well about the cost of health care. And we did an extensive survey last year, and healthcare costs are among the top four, but didn't predominate like that what it has in past years. But I would offer two observations. One, premium growth has moderated in the last few years, so unlike the 5 or 6 or 7 years ago when employers were getting double-digit increases and our phones were ringing off the hook. We haven't experienced that recently. But my other observation is in certain industries, and particularly manufacturing, and 30% of our members are engaged in manufacturing where costs really do matter, and they participate in the global environment. It's still a really important issue for them. So just wanted to share those observations with you as well.
Yep, agree. Thanks.
Thank you, Governor. I was interested in your comments on alternative payment mechanisms and the penetration rate. And you rightfully said the denominator is confusing at times. Most of the data that we've seen is that 50% penetration rate is primarily in the HMO population. And obviously with Medicare's strong push, very aggressive and ambitious goal in the next several years to get that number for Medicare patients up to 50%, we may have quite a ways to go. Do you have any thoughts or suggestions to the Commission as to what we can do to try to move that number up, that enrollment and participation on both the patient and the clinician side, to something that can give us much better results than we've had to date?
Results in terms of the rate of participation in that type of a model, or results
exactly.
Yeah, okay.
Exactly. In that when it works, effectively, we do get less expensive but still high-quality health care.
I think the biggest way you could move the needle on some of this is to highlight where it's been successful, and to do it a lot. I mean, one of the things I've certainly learned in my time in public life is you have to say something over and over and over and over again before it actually penetrates. And I think on the alternative payment methodologies, if Medicare moves in a significant way in that space,
No problem.
they are kind of the chassis that everybody keeps score on, so that makes a huge difference. But a lot of what Medicare does also preserves some of the stuff that people express concerns about with respect to the facility-based and the technology-driven approach to reimbursement, which has kind of dominated our market and the healthcare sector overall for as long as I can remember. So if Medicare were to truly move in a big way in that direction, that all by itself would move a lot of other people along with it. Because everybody does keep score based on what Medicare does, for better or for worse.
I'm so appreciative of your time, Governor, and of course, you didn't let me down. You hit all the points that we need to focus on, and I'm looking forward to the rest of the conference. And we will assure let you know if we find some nuggets.
We're looking forward to the rest of the conference too. You got a lot of terrific players coming to spend time with
So
you.
thank you so much for joining us. It's really been a pleasure.
Thank you.
Thank you, Governor. And just as a program note, unfortunately, the Senate